to begin the second half of the CME lectures this month dedicated to oncology. And I want to remind you on the way out, you can pick up a copy of the remaining schedule in yellow. It shows that we still have 3 great lectures remaining, one this Thursday as well as 2 next week, and I invite you to attend. Our speaker today, Dr. Raymond Tatevossian. His medical career started at Memorial University in Canada, where he graduated medical school. He then underwent residency training in anesthesiology at USC Medical Center, followed by a fellowship in pain medicine, and is currently board certified in both anesthesia and pain medicine. He stays connected to the USC pain program as a clinical assistant professor of anesthesiology. Currently, he is a member of Buena Vista Anesthesiologists Medical Group, working here both at Providence St. Joseph Medical Center as well as Holy Cross. He also is chair of the Pain and Palliative Care Committee here at Providence St. Joseph's Medical Center. Despite his busy schedule, he still acts as a reviewer for the Journal of Pain Medicine, looking over clinical research to stay current. So without further ado, Dr. Raymond Tatevossian.
It's a pleasure to be here today to talk about my presentation here, current concepts and strategies in pain management. This is a very large topic, but I want to really focus on a few lecture objectives here today. These include current understanding of pain mechanisms. I want to talk about current treatment strategies. I want to give you a medication update, some emerging medication and concerns about existing pain medication. I want to focus a little bit about opioids and talk about a growing controversy surrounding opioids, and also make some recommendations for prudent opioid prescribing. And also I want to end by discussing some advanced interventional techniques that we can include in our pain management strategies. So some of the statistics behind pain. Pain has a very widespread effect on society. It's the second leading cause of medically related lost work days. This translates into about $100 billion per year cost to the U.S. economy. On an individual level, in a recent survey, 42% of adults stated that they experience daily pain. And half the population, when they come see doctors, their chief complaint is pain. When they polled our U.S. veterans returning from military service, 66%, or 2/3, said that they had persistent pain related to their military service. So it's a very widespread problem. But before we say that all pain is bad, we should put pain in perspective. And we can do that by looking at the work of Dr. Paul Brand. Dr. Brand was a British-born hand surgeon who worked in India in a missionary hospital in the 1950s. And he wrote a book called The Gift of Pain. And through his work treating hand wounds and injuries, he stated that pain is really the beloved enemy. And he reflected that pain is evolutionarily necessary for survival, and that really acute pain is protective. And he said this, and based on experience with this disease. Anybody know what this is? Yeah, this is hands from leprosy. And it's an infectious process. The bug is Mycobacterium leprae, and Dr. Brand treated a lot of leprosy in India, and he noticed that every time that he casted the hands of the wounds that he treated, put a full cast around them, they would have healing. There would be the disfigurement would stop. There would be improved healing, and the patients would do better. So he started asking himself the question. At that time, the prevailing notion was that the disfigurement was from the infectious process and not from some other cause. So he started asking the question: Is this infection, or is it really the fact that the patients have painlessness from the disease? So what he did is a very interesting test. So after he treated the wounds of leprosy, patients with leprosy, he told them, he said, when you go home to your village, when you go home tonight, tie a cat to your bedpost. And so a group of patients did that. And he noticed all the patients that tied cats to their bedposts ended up doing better. Their wounds would heal, and it would slow down this disfigurement. So what was happening was at night, because these patients were painless, the rats were coming and chewing on the fresh wounds and on the fingers. But with the cats there, they wouldn't, that process wouldn't occur. So the conclusion was that acute pain is protective, but chronic pain is a disease. To understand more about the differences of the two, we should look at the difference between acute and chronic pain. So acute pain, generally protective. It's relieved when healing is complete. It tends to be of short duration. It tends to be of predictable pathology. And the prognosis is predictable. And treatment is usually unidimensional with analgesics. However, chronic pain is different. Chronic pain is, generally has no useful function. It persists even after healing is complete, and we'll talk about some of the mechanisms that cause this. It tends to be of long duration. It tends to have an unpredictable pathology and unpredictable prognosis. But the treatment is different. The treatment is more multidisciplinary and multidimensional. We'll discuss that more. So really we're going to focus today on chronic pain. But some of the things that we learn about chronic pain, we can apply it to acute pain, and we can also apply it to the idea of to treat acute pain aggressively so we prevent chronic pain. To discuss a little bit about the different chronic pain conditions, we can break these down into neuropathic conditions. So chronic pain that is a result of a disruption in the peripheral or central nervous system, such as diabetic neuropathy, postherpetic neuralgia, phantom limb pain, a complex regional pain syndrome, or what they used to call RSD. There's nociceptive pain, like osteoarthritis, so pain that's arising from somatic or visceral structures. And then there's mixed pain, a mixture of both neuropathic and nociceptive, like cancer pain, chronic headache, migraine, fibromyalgia. So it's important to know the differences between these different types of categories because, for example, the treatment would differ. For example, neuropathic pain doesn't respond as well to opioids as nociceptive or mixed pain. So to discuss a little about the treatment options, we have to look at some of the factors that contribute to chronic pain. And clinically, there's this idea that there's a chronic pain load. And as this load gets heavier and heavier, we're more likely to develop chronic pain. And this load is based on some factors: the intensity of the injury, the duration of the injury, so if a long period of time before the patient gets treatment, the repetitiveness of the injury, so if you injure the same area multiple times, or maybe if you undergo multiple surgeries in the same area, the chronicity of the disease itself. If you have diabetes uncontrolled for many years, there's a chance you'll have more progressive neuropathy. And even there may be genetic predisposition. Some people have looked at patients that have certain haplotypes of genes that produce less BH4 enzyme production, and they correlated this decreased BH4 enzyme production to less pain after surgery. So there may be some genetic factors. And other very important factors are psychological factors. If there's any underlying depression, anxiety, person's cognition, their emotional state, socioeconomic factors, person's environment can have influence on pain, and even cultural factors. They've looked at certain cultures have higher pain thresholds than other cultures. But to really explain how chronic pain develops, we have to look at the neurobiology and the mechanisms behind that to answer that question of how we get chronic pain. And to answer that, we have to talk about neuroplasticity. So neuroplasticity is basically the idea that the nervous system is not hardwired. It's not static. The nervous system undergoes dynamic reorganization at all times. During injury and even after the injury is healed and there's no more injury, the nervous system is undergoing reorganization. And this reorganization sets us up for chronic pain. And this is described by two phenomena: peripheral sensitization and central sensitization. So peripheral sensitization is the idea that after an injury, there's a release of these inflammatory mediators. Some people call this a sensitizing soup. So there's an injury somewhere to the skin, and there's release of bradykinin, cyclooxygenase pathway mediators, histamine, substance P. And these mediators end up causing increased sensitivity of peripheral pain receptors. They do that by decreasing the threshold and increasing the response of the pain receptors. These are the A delta and C fibers. And once this sensitivity process begins, that's out in the periphery. Once we get to the central nervous system, we call this central sensitization. And that's the idea that there is this reorganization. There's this increased excitability. There's synaptic recruitment and decreased inhibition. So this whole phenomenon that's resulting in chronic pain. And what's happening is that there's uncoupling of pain from peripheral stimuli. So even when there's healing here and the wound is gone and the injury has been treated, there is still this reorganization in the central nervous system that now we have an uncoupling. So now when the patient brushes up against something, they still have sensitivity, they still have pain. Sometimes we call that allodynia or hyperesthesia clinically. But the pain is still being perceived, the signals here, and it's being sent to the brain. So now that we know these mechanisms, we can apply treatments. We can try to disrupt this pathway. We can do it by, in the OR, we do this all the time. Surgeons typically infuse local anesthetic before they make an incision. Medications, local anesthetics, topical agents, anti-inflammatory medications have receptors here. We do nerve blocks often to treat pain and also to prevent pain before in surgery. We can do epidurals or spinals, or we prescribe medications such as opioids that have receptors here, again trying to disrupt this pathway and prevent the sensitization happening because of plasticity. So there are multiple treatment options, and most of us are aware of this. There is pharmacotherapy, multiple different classes of medications, opioids, anti-inflammatories. Some people use neuroleptics like gabapentin or Lyrica. There are NMDA antagonists like ketamine. Other approaches include interventional approaches, all different types of injections, steroid injections, and we're going to talk about, again, these are injections to try to prevent that process of sensitization. We're going to talk about in the end of the talk about neurostimulation and neuromodulation, more advanced therapies. Psychological support, we saw that psychology has a factor in developing chronic pain, so providing proper patients with access to psychologists, psychiatrists, controlling the depression, biofeedback, stress management, lifestyle changes. Sometimes people have certain jobs that they have chronic heavy lifting and chronic stress at work, and so we can look into changing job descriptions, weight loss. Physical medicine rehab is very important, getting patients into physical therapy early. Occupational therapy, looking at their home environment or their work environment, trying to optimize that environment, assist devices. And finally, alternative medicine is growing importance, getting patients involved in acupuncture, relaxation, with techniques such as Tai Chi. So there are multiple treatment options, and traditionally, we've looked at these treatment options in a stepwise approach. And this is still an accepted management strategy where there's this continuum. As the pain gets worse, as the pain doesn't respond to one therapy, we move up the ladder and we start low and we go to more aggressive therapies, stronger medications, more involved injections as we go up the ladder one by one. And this is still accepted, but really what we want to talk about is multimodal pain management or multidisciplinary pain management, where we get the patient, the proper patient, involved in multiple disciplines early on, and then we can reassess as time goes on. And there's good evidence-based medicine to show, category A evidence, that this multimodal type of pain management, again, for chronic pain, shows good outcome when compared to conventional therapy. A lot of the studies are still short-term, and we're really talking 6 months to a year. And the longer studies are still, we're still waiting to see those results. But now that we know our treatment options, let's talk a little bit about some of the goals of treatment. So obviously reduce pain. Some people say if you have a 50% reduction after an injection, that's a positive result. And sometimes we can't, no matter what we do, we still can't get those pain scores lower. In those cases, we try to increase activity levels, increase the quality of life. So even if the pain is the same after 6 months of treatment, if the patients are more active, if they're happier, they're involved with their family members or friends more often, they're taking longer walks, and sometimes that's a positive endpoint and result. One of our other goals is we always try to take advantage of preemptive analgesia, and we do that in the OR all the time. We inject local anesthetic before we make an incision. We do spinals or nerve blocks before the patient undergoes a surgical procedure to try to prevent that sensitization and development of chronic pain. And then one other thing is, one of our other goals is to stay within a therapeutic window. If we can extrapolate from pharmacology that in any treatment there's a therapeutic window. So there's this window where you have some positive result, And where if you do too much medication, too much treatment, you'll have toxicity. If you undertreat, or if there's not enough treatment, you have undertreatment, no result. So you want to stay within this therapeutic window. How you do this is by a few things. One is you take advantage of synergism. So synergism is the idea that you can use two medications or two treatments at lower dosages and obtain the same, if not better, result with less side effects than if you use that one treatment by itself. For example, using morphine at 100 milligrams, you could use morphine at a lower dose in combination with another drug. And actually, in a New England Journal study, and I have all these studies in the references, in a New England Journal of Medicine publication from 2005, they looked at morphine and gabapentin in combination, was able to provide adequate pain relief at lower dosages if they use morphine alone or gabapentin alone. And you can, this synergism idea, you can use it with anything, multiple medications, multiple treatments. We can do physical therapy, have the patient see the psychologist, consider an injection, consider a medication to stay within this window. And also, the other way to stay within this window and expand this window is use multimodal pain management strategies. Sometimes this becomes very difficult, especially in cancer pain and malignant pain. As the disease progresses, this window gets narrower and narrower and narrower. So we give more medication, and the patient is uncomfortable, so we have to give even more medication or more aggressive therapy to the point where we get very close to this toxicity level, and that could be quite a challenge. In those instances, again, we try to apply every avenue of treatment that we have to try to keep this window nice and open. So I want to shift gears a little bit here and discuss a little bit about medications, pain medications, and tell you about some emerging medications and also some concerns about existing medications. Last summer, the FDA advisory panel got convened and made some recommendations to the FDA. These were just recommendations, and the FDA has to make the decision whether they're going to follow through with them. And some of the recommendations were that they felt that acetaminophen, that the maximum daily dose should be decreased from 4,000 milligrams. They didn't say what dose, but they said it should be decreased. And the maximum single dose, which is 1,000 milligrams at a time, should be decreased to 650. And again, this was based on their concern about increased toxicity with multiple medications out there, over-the-counter and prescription, that have acetaminophen in them. They recommend an altogether ban on Vicodin, Percocet, on all these short-acting medications that are tied in with acetaminophen. And they said that these medications are fine, but just have them available separate from acetaminophen. So hydrocodone by itself, oxycodone by itself. They also recommended a phased withdrawal of propoxyphene, which is the active drug in Darvocet or Darvon. And they cited the increased toxicity, increased complications with it. They said that in some studies showed it's no different than acetaminophen. The pain and the FDA didn't really act on any of this. They're reviewing it. I think they've forced the pharmaceutical companies to increase the labeling of these medications. But a lot of the pain societies are concerned about these, and they consider it would be an increased barrier if some of these if there's increased bans on these medications, because there are always patients that respond. There are patients that do really well with propoxyphene. And what it really takes is a good one-on-one conversation with the patient when you're prescribing these, so they know about the concerns and pitfalls. There are these whole new class of drugs that are coming out called abuse-deterrent opioids. Again, there's increased concern about toxicity and overdose and deterrence of medications. So this new class called abuse-deterrent opioids, where a known medication like morphine or oxycodone is in combination with an antagonist medication. So naltrexone is a mu-opioid antagonist. So if somebody is overdosed with opioids, with morphine, and if you give them naltrexone or Narcan, they'll wake up. So what they're doing is they're tying in this medication with morphine, but the naltrexone is sequestered. So if the patient crushes it, tries to inhale it, inject it, the naltrexone will give them a dysphoric reaction. So this medication Embeda is already on the market. Other ones with oxycodone, Oxytrex, and they've even incorporated niacin. Niacin gives you flushing, so if you try to take it the wrong way, you'll have a bad reaction. But the studies are not out to say whether this is going to really work or not. Some emerging medications that you might see on formulary that you might consider in your practice. IV acetaminophen, paracetamol. It's been used in Europe for many years. It's just completed phase 3 trials here in the US. It's waiting final approval. And opioid sparing, so patients who get IV acetaminophen have less of a requirement for opioids. And again, another option if the patient's MPO. It's also used for, I think, antipyretic use also. Tapentadol or Nucynta is a new medication that's out. It's a mu opioid agonist, just like morphine. It's a Schedule II, but it actually has a norepinephrine reuptake inhibitor effect. So we can use it for neuropathic pain as well. And they're marketing it with less GI side effects, so less constipation, less dysmotility and irritation, GI. But we only have the short-acting form right now. The long-acting form is in trials. Hydromorphone extended release. So a lot of us like to prescribe Dilaudid because patients are sensitive to morphine. Now the long-acting version of Dilaudid is available. It's called Exalgo. It's been approved, but it's waiting this process called REMS, which we'll talk about more in the next slide, or next coming slides. So now I want to talk a little bit about opioids and the growing controversy regarding opioids. Opioids are still the gold standard for pain in general, but there's been this increased concern about them. But before I want to take you back to the beginning and tell you the story from the beginning and how we kind of got to this level. So 1990, pain becomes the 5th vital sign. We all remember that. And at the same time, the Intractable Pain Act was passed, where it said no physician or surgeon shall be subject to disciplinary action for prescribing controlled substances for intractable pain. So we're in this era of decreased scrutiny, increased emphasis on pain control, prescribing, being more aggressive. The Medical Board of California defines undertreatment of pain as inappropriate prescribing. And this culminates and reflected in a case, Bergman versus Chin. Dr. Chin, taken to civil court, and a judgment was made against him for $1.5 million. I think it's one of the only cases of its kind for undertreatment of pain by the family of Bergman, who was a dying cancer patient. So all this results as we get closer to 2000, and now all of a sudden there's a 35 to 50% increase in opioid prescribing. So let's go to the present. Now we see an era of increased scrutiny. Now opioids become the most common class of medications prescribed, 800% increase in 10 years. Fatal opioid poisonings have tripled from 1999 to 2006. Number one cause of death in young people used to be MVAs and trauma. Now it's poisonings. 40% of that is from medications, opioids in particular. And I think in even some states, I think 16 states, opioids are the leading cause of, or poisonings from opioids are leading cause of death in young people. So under a congressional mandate to kind of curb this and have increased scrutiny, the FDA, the Food and Drug Administration Act was passed in 2007, and this gave the FDA kind of an increased watchdog over this process and the FDA created this process called REMS. REMS is Risk Evaluation and Mitigation Strategy. So every time a new medication comes on the market, any medication, but specifically opioids, comes on the market, the FDA reviews whether the risk-benefit ratio of this medication, and then decide, and then because through this process puts in a few, not barriers, but a few things that everybody needs to go through to prescribe these medications. The pharmaceutical companies have to have special warnings. The doctors have to have special training. The patients get enrolled in a database. So there's been a lot of criticism of this, that it puts, again, people who are prescribing in a bad light, and that there are increased barriers for patients who are suffering from pain. So, and then in January 2000, same in the area of increased scrutiny, in January 2010, McClellan and Turner, in the Annals of Internal Medicine, in an editorial, said that, and this is for non-cancer pain, said prescribing opioids at high doses is both dangerous and questionable. Okay, so that's one doctor's opinion, not a big deal. If you read the bottom of the article, guess where it's coming from? White House Office of National Drug Control Policy. So this article produced a lot of heat. All the pain societies came out, a lot of emails, and what they said was that this puts doctors in a bad light, because there are patients who don't have cancer who have high dose of opioids and do well. And it's too much of a blanket statement. So, you know, the journal came, actually the White House in turn said, well, this is not, they don't reflect our opinion. This is the opinion of these doctors who are related with this policy, but with the White House, but it's not the official policy. But again, you can see this area of increased scrutiny. So where does it take us for the future? So there's still undertreatment of pain is still, and nobody questions this, is still a major problem. But at the same time, I think we realize that abuse, toxicity, deterrence is also a growing problem. So we have to strike a balance. And the way we can strike a balance is by knowing some prescribing strategies, accepted prescribing strategies for opioids. Number one, know the difference between immediate release and sustained release. So short-acting versus long-acting. Vicodin, for example, short-acting, fentanyl patch, methadone, long-acting, OxyContin is long-acting. Short-acting more for acute pain, pain for short duration, post-surgical pain, or some kind of acute pain that we think is going to improve with time. Long-acting is more for chronic pain. Know the difference between neuropathic and nociceptive pain. Neuropathic pain being more pain, nerve pain from the central peripheral nervous system, doesn't respond as well to opioids as nociceptive pain does. Appreciate the difference between cancer pain and non-cancer pain. We're a little bit more, with cancer pain, we're more aggressive with opioids. With non-cancer pain, we can still use opioids for non-cancer pain, but we want to include multidisciplinary approaches, other approaches as well. Urine toxicology screens, use these in your practice. They've become very, very sophisticated. You can actually screen, you can do a basic screen, you know, if their patients are any drug abuse, but also you can do a very sophisticated screen. You can tell which opioid they're taking, which dose they're taking. So if you prescribe the patient OxyContin 30 BID, the screen, some companies will actually tell you that what the values that they found was too high, that the patient's using it, that they're taking too much of it. Or the screen might show that their patient's not taking enough. So they're saying that they're still running out of all their medication. So where's that medication going? So it's become very sophisticated. And this is billable, so it's reimbursable. Opioid contracts and prescription monitoring. Other things that we can do, this is part of strategic opioid prescribing. Prescription monitoring. There's a new program in California. It's called the CURES program. And which basically allows for, there's an online database in California. Every state, I think different states have them, but in California it's called CURES. And it's an online database where every time a patient fills a prescription, that query goes on this database. And we can, pharmacists, physicians, and even drug enforcement has access to that database. But as physicians, we can sign up for that database, and you can check right away if the patient is doctor shopping, if they're going to multiple doctors to get prescriptions, if they're using the medication appropriately. And to do that, you can go to the website. I provided the website here, and you basically, I think you sign up, they send you an application, you fill the application, get it notarized, and then you can have online access to this program, this CURES program. Opioid contracts are a good idea. Some people say don't call them contracts because they have a negative stigma. Call it opioid consents. You can use this in your practice. If you want an example, you can send me an email or contact me through the staff office. But so opioid consents before you, and this is more for long-acting medications, or if the patients are, if you're prescribing significant amount of opioids, and you can discuss the risks, benefits of these medications. So the risk of dependence, the risk of addiction, the risk of, if they take it the wrong way, the risk of complications. It's an educational process for the patient. And also you establish some rules of prescribing. You tell the patient, listen, generally I'm not going to give early refills. You have to get the medication from a single pharmacy. You have to get the medication from a single physician. If you want to get it from another physician, they have to contact me. If the patient loses the prescription, they have to have a police report before you give them another one. If the medication doesn't work, we'll consider other therapies. Not necessarily we're going to keep going up. So again, it's an educational risk-benefit, protects the patient, protects you. So now I want to discuss a little bit about some advanced interventional techniques that we use in that multidisciplinary approach for chronic pain management. Intrathecal drug delivery systems, also known, some people call them pain pumps. And what they are is the implantation of a reservoir in the superficial, either abdominal wall, in the superficial tissues, or in the buttocks. And the active drug is inside here, and it's delivered by a silastic catheter into the spine, into the intrathecal space. The mechanism of action is that the drug is delivered directly to the intrathecal space. So right where the receptors are. And because of this ability to deliver it there, we'll see in the next slide, there has a lot of benefits. The drugs that are available, the FDA-approved medications include morphine for pain, but other opioids we can use also, baclofen for spasticity, but also for pain, and new medications, ziconotide, which is an N-type calcium channel blocker that they've isolated from snail venom actually, but it works very well for neuropathic pain. Other medications we can use on an off-label basis, and there's a whole algorithm that we can go through to know which medication to use and when to change from one to another. The pros and cons for this therapy. The pros include we do it on a trial basis. So the patient gets a trial without the actual implant, without the actual surgery, and if it works and if there's a response, then they would get the implant. The other benefit is the medication is delivered directly to the site of action, directly to where the pain signals are, where the receptors are, and because of this, we can use lower dosages. 1 milligram in the spine is the same as 300 milligrams oral morphine. So lower dosages means less side effects. In a very nice study in the journal Clinical Oncology, prospective randomized study for cancer pain, it showed that patients had less, when compared to conventional therapy, they had less pain, less side effects, less toxicity, and increased survival. Even at 6 months, the patients were thriving. So because they had less pain, and because they had less side effects from high dose of medications, the patients were actually doing better. So we tend to be a little bit more aggressive with this therapy with cancer pain than we do with non-cancer pain. Some of the cons, the short reversible trial. So we don't really know long-term what's going to happen. In fact, some studies have showed that there's decreased opioid benefit with time, 40% failure in 1 year. So then you have to go to another medication. This can be kind of cumbersome, shifting medications, taking medications out, putting in new medications. There are a lot of contraindications to placement, things like coagulopathy, sepsis, and some of our patients who benefit the most, our cancer patients, have some of these issues, so it precludes us from placing them. And there are some complications. Other than normal post-surgical complications, there are some late complications, such as the formation of granuloma or inflammatory reaction that happens at the tip of the catheter inside the spine, which can cause problems. Happens more with morphine at higher dosages. So another advanced interventional technique that we use in our multidisciplinary pain management strategy is called spinal cord stimulation. This is the idea that is defined as the production of an electrical field over the dorsal columns by epidurally placed electrodes. So this electrical field is produced over the spinal cord, you can see over here, this is an electrode that was placed epidurally, so no real incision. And this is a picture of a thoracic spine. You can see the ribs. And the lead is attached to an external generator. And the generator delivers a current that produces this electrical field over the spine, or spinal cord, sorry. And the physiology behind this is all based on the gate control theory. So the gate control theory was a theory in 1965 written by Malzik and Wall, who said that there's a gate that exists in the dorsal horn or the posterior portion of the spinal cord that governs the transmission of pain signals to the brain. And that if you can close this gate, you can stop the transmission of, the idea is if you can close this gate, you can stop the transmission of pain signals. The way you do that, and they said in their theory, is that the gate opening or closing has to do with the relation of small fibers to large fibers, so excitatory and inhibitory fibers. And so clinically, what the patient feels when you have the lead there and you have this electrical field is they feel a paresthesia. They feel tingling over the painful body area. So for example, if the patient had severe pain in their hand, you would put the lead in the appropriate place over the spine and to try to produce that paresthesia. And we do this with the patient awake or sedated so they can tell us if they feel it. The reason we know where to put these leads is because of very elegant work done by Berlot, who basically, in awake patients, put these leads all over, up and down the spine, and was able to map out. So left shoulder, you would place the lead, for example, in the mid-cervical area. Low back, you place the lead in T8. So we have the map for these leads. One of the beauties of this therapy is that it's placed on a trial basis. Again, there's no incision. They get the lead. They go home with it. They have an external battery. Same technology that Dr. Young talked about when he did deep brain stimulation. And they go home, and after a week, if they have a positive trial, they feel the pain was reduced significantly, they're using less medications, then we would implant the system. When we talk about evidence-based medicine for this spinal cord stimulation, there's grade A evidence for failed back surgery syndrome or patients who had laminectomy, decompression, continue to have significant pain for arachnoiditis. There's grade B evidence, which is still fairly decent evidence that it works for CRPS 1 and 2, which is complex regional pain, or what we used to call RSD. Other indications, really a lot of neuropathic conditions, phantom limb pain, postherpetic neuralgia, spinal cord injury, and these same leads, now we're starting to, not only are we putting them in the spine, we're starting to use them off-label now peripherally. So we can place them just subcutaneously or along a nerve. So if a patient has inguinal neuropathy after inguinal surgery and it's severe, we can actually put the lead next to the nerve. So a lot of new things coming out with spinal cord stimulation. And we try to incorporate this into our multimodal pain management strategy. And maybe the old thinking was wait until the medications fail, wait until physical therapy fail, if it's a significant chronic pain condition like ours, and then they'll slowly graduate into obtaining this therapy. But what a lot of people are advocating for is that you can incorporate this stuff early on as part of their multidisciplinary approach. So thank you very much. I want to thank Dr. Gayan for help with this presentation, and these are some references for your thanks.